Good morning, everyone. Today I'm presenting liver disease in pregnancy. So, to start with, as we know, the pregnancy is a state of altered yet normal physiology. There is increased serum estrogen and the progesterone levels, which affect the synthetic and the metabolic function of the liver. So, it is important to know the changes that occur in the pregnancy for the correct interpretation of the liver function test. Also, many normal physiological changes in the pregnancy mimic chronic liver disease that are spider angiomatous and the Palmer erythema, which disappear after pregnancy, and hyperestrogenic state is responsible factor. Physiological changes that seen in the pregnancy which affect the liver are total plasma volume increases by 50% between 6 to 36 weeks of gestation. There is a state of the hemodilution and the lowering of the hematocrit level. Cardiac output increases till second trimester and then decreases and normalizes near term. There is absolute blood flow to the liver is unchanged. However, percentage of the total cardiac output of the liver decreases. Serum albumin decreases due to the hemodilution and the decreased synthesis. Serum cholesterol and the triglyceride are markedly increased due to the increased synthesis. Serum alkaline phosphatase increases in the third trimester, but its increased production of the placental and the bone isoenzymes. Serum aminotransferases are almost unaltered. Serum GGT level decreases slightly during the late pregnancy only. Serum bilirubin level total in the free bilirubin lower than the non-pregnant females in all trimesters. Direct bilirubin lower than the normal in the second and the third trimesters. And the fasting serum total bile acids are within normal limit. Hence, elevated levels of the AST, ALT, serum bilirubin and the total bile acids to be considered pathologic as in the non-pregnant woman. So this is a tabular form of these findings only. So now safety of the diagnostic test, as we know that ultrasound, elastography and the MRCP, they are safe in the any gestation of the pregnancy and can be done. While the ERCP and the duodenoscopy that are done preferably in the second and the third trimester of the pregnancy and the preferably in the left lateral position. Liver biopsy is rarely indicated when the diagnosis will change the outcome of the pregnancy. Now, liver disease in the pregnancy. Broadly, we classify the liver disease in the three categories. So they are, one is the pre-existing underlying liver disease, which are chronic hepatitis B, C, autoimmune hepatitis, Wilson's disease, primary biliary cirrhosis, primary sclerosing cholangitis, and cirrhosis of any cause. They can occur in any trimester of the pregnancy. Diseases which are coincidental with the liver disease with the pregnancy are acute viral hepatitis, that is hepatitis E infection, the hepatitis A infection occurring in the pregnancy, gallstones, Budd-Chiari syndrome, drug-induced hepatotoxicity, and the sepsis. But there are certain diseases, because these all two categories are vast and I'm not covering in my today's topic. I will only discuss about the diseases which are unique to the pregnancy. They affect 3% of the pregnant population and they resolve with the termination of the pregnancy. They are mainly hyperemesis gravidarum, intrahepatic cholestasis of the pregnancy, HELP syndrome with the preeclampsia, and the acute fatty liver of the pregnancy. So today I will discuss in detail about these diseases. So first is hyperemesis gravidarum. The incidence of the nausea and the vomiting in the pregnancy is overall 80%. But the incidence of the hyperemesis gravidarum, which is severe form of the nausea vomiting, is 0.3 to 3.6%. Diagnosis is with the triad of the triad is, that is the protectic vomiting occurring with more than 5% of the pre-pregnancy weight loss, dehydration, and the electrolyte imbalance. The pathophysiology is poorly understood. Immunologic, hormonal, and the psychological factors are thought to play a role. Risk factors are young age. Can we remove this upper one also? So the risk factors are young age, primary gravida, multiple pregnancies, obesity, hyperthyroidism, psychiatric illness, molar pregnancy, and the pre-existing diabetes and the tobacco use. 50% of the patient require hospitalization, and out of these 50% of these have liver dysfunction. There is minimal to several fold elevation in the aminotransferases levels. ALT is more risk than AST. Mild unconjugated hyperbilirubinemia is there up to 4 mg per deciliter. Pruritus is rare and mostly there is no abdominal pain. Hepatic dysfunction is thought to be related to dehydration, malnutrition, and the electrolyte abnormalities. Symptoms usually resolve at 14 to 18 weeks of gestation, but may continue until the third trimester in 15 to 20% of the patients, even until delivery in 5% of the patient. So it is the clinical interpretation of the patient and the investigation workup. In the history, first of all, if the patient comes with a hyperemesis gravidarum, we have to quantify the severity using PUQE score. So this score is based on the mainly three questions. And these are in the last 24 hours, how long you have felt nauseated or sick to your stomach. In the last 24 hours, have you vomited or thrown up? And in the last 24 hours, how many times you have retching or dry hips without breathing anything else. So, according to these three basic questions, we quantify the patient. We give the total score is 25, and we put the patient mild when the score is less than 6, moderate 7 to 12, and the severe 13 to 15. So according to this PQE system, we start with the workup and then we take the basic baseline investigation of the patient. We see the vitals, and important things to note are the urine dipstick to quantify the ketonuria, see the serum urea and the electrolytes, blood glucose monitoring, and in the refractory cases, history of the previous admission, check the thyroid level, LFTs, amylase level, and the ABG also. So after this quantification, we uh, we put the patient in the two categories. When the score is 3 to 12 and there is no complications, antiemetics are given for home, and the patient is suggested for the lifestyle and the dietary changes. When the patient score is 13 or above but there is no complication, then daycare management is sufficient in the form of the fast intravenous hydration with normal saline and antiemetics and the thiamine supplementation. If the score is any score but with associated with complication, and when the daycare management is unsuccessful, we admit the patient. We give the patient, apart from these normal management, we give the patient the thromboprophylaxis and consider steroids also. So these are the recommended antiemetic therapies. The first line drugs are the cyclizine, prochlorperazine, promethazine, and the chlorpromazine. Second line drugs are the metoclopramide, domperidone, and the ondansetron. The refractory cases, we consider the corticosteroids, hydrocortisone, and the prednisolone. So the complications of the hyperemesis are fundus encephalopathy, renal damage, retinal hemorrhage, pneumomediastinum, and the spontaneous esophageal rupture. Favorable outcome with the adequate supportive therapy is seen. Infant born do not differ in regard to birth weight, gestational age, and the birth defects from infants of the unaffected mother. Second discussion is about the intrahepatic cholestasis of the pregnancy. The diagnosis of the intrahepatic cholestasis of the pregnancy should be considered in pregnant women with itching in the skin of the normal appearance and raised peak total bile acid concentration that is more than 19. It occurs in the second and the third trimester of the pregnancy. It disappears spontaneously after delivery. Prevalence in the UK is 0.7%. It is double in the Indian Asian community, and the highest rate is seen in the areas of the America, that is Kyle and the Bolivia. Cause is unknown. Genetic, hormonal, and the environmental factors play a role. Genetic component, that is heterozygous mutation in the biliary transporter, that is ABCB4, B11, and the ATP8B1. So they codes for the multi-drug resistance P-glycoprotein 3 called MDR3. The cholestatic impact of the elevated concentration of the reproductive hormones. They unmask symptoms of the biochemical features of the ICP in genetically susceptible individuals. So the symptoms are pruritus, severe and the intractable, more intense in the night. Usually that occur in the third trimester, rarely in the first trimester, which disappear within the first few days of delivery. Usually it is generalized, starting peripherally and spread centrally. Predominant on the palms and soles, excoriation secondary to the scratching can be seen. Jaundice present in the 10% of the patient, usually occur 2 to 4 weeks after the onset of the pruritus. If it precedes pruritus, rule out other causes of the liver disease. Diarrhea with the steatorrhea may develop, no abdominal pain or the encephalopathy noted. In the AST, we do the ALT, that is 2 to 10 times of the normal, may be high enough to suggest viral hepatitis sometimes. Total bile acids, fasting level of the conjugated bile acids and especially cholic acids are elevated. It is the most sensitive and the specific marker of intrahepatic cholestasis of the pregnancy. Serum ALP level may be elevated, but that is not specific. Prothrombin time, GGT usually normal. Ultrasound, in the ultrasound, normal liver with the non-dilated bile ducts are seen. Liver biopsy rarely done. Whenever it is done, it is blind cholestasis with minimal or no inflammation. Bile plugs in the hepatocytes and canaliculi predominantly in the zone 3, and the portal ducts are unaffected. Complications are no associated maternal mortality with this disease, but it may be significant fetal morbidity and the mortality. Fetal prematurity becomes meconium stain like a increased risk of the fetal respiratory distress syndrome, sudden fetal death, usually in the last month of the pregnancy. No ideal method of the fetal surveillance for this disease. The delivery of the fetus leads to resolution of the symptoms. Fetal complication increase when the serum bile acids are more than 40. So it is the clinical work of this the ICP. We start with the investigation. The initial investigation, we see the total bile acid level, transaminase levels. If the both are normal, we put the patient in category 2. When the both diseases are normal, then if the patient is less than 32 weeks of pregnancy, we keep repeating the investigation every 2 to 3 weeks until and after 32 weeks we repeat the investigation every weekly till delivery. According to investigation, they still lie in the normal range. We continue as above. But if they increase, we put the patient in the category 2. In this category 2, we do first of all, we exclude the other causes of the hepatic impairment. That is the maternal disease that may present with the elevated bile acids like the HCV serology, autoimmune hepatitis, and extrahepatic biliary absorption. So, also we have to rule out AFLP and the HELP syndrome. If pruritus persists in these patients, we repeat the investigation every 2 weeks in less than 32 weeks of gestation and then weekly until delivery. In the category C is when the both are raised, both investigations are raised. In these patients, first of all, we exclude the other causes of the this raised investigation. And if above are negative, diagnosis goes in favor of the ICP. Consider drug management for these patients. So, if the bile acid level is less than 40 and it is a less than 34 weeks of gestation, consider the ursodeoxycholic acid treatment weekly and then weekly repeat the investigation and induction by 39 weeks of gestation. If it is between 400 to 40 to 100, the treatment is as same but till the 37 weeks of gestation and induction at 39 weeks. But if the levels are more than 100 and the patient is more than 34 weeks of gestation, then recommended delivery from 35 weeks of gestation. So now the treatment is the pharmacological treatment is first line is the ursodeoxycholic acid. It improves the symptoms, bile flow, and the biochemical test results. There is no significant material in the fetal adverse effects. It restores the transport capabilities of the placenta, which are affected in the ICP. Dose recommended are 10 to 15 milligram per kilogram per day in divided doses. Other treatments are cholestyramine and the SAMs, but they show their effect best when they are used with ursodeoxycholic acid. Antihistamines may aggravate the respiratory difficulties in the preterm babies. Cholestasis can lead to deficiency of the fat-soluble vitamins also. So vitamin K should be given to all patients to prevent the postpartum hemorrhage. Now, recurrence is 60 to 70%. There is increased risk of the gallstones in these patients. Subsequent use of the oral contraceptives is associated with recurrence of the pruritus. But ICP per se is not a contraindication of their use, considering the condition is completely resolved after pregnancy. Combined OCPs with the low dose estrogen, the progesterone only contraception can be given. Next condition is acute fatty liver of the pregnancy. It is a sudden catastrophic illness characterized by microvascular steatosis associated with mitochondrial dysfunction. Incidence is 1 out of 10,000 pregnancies, so it is very rare condition. Risk factor is extremes of the maternal is low BMI, pregnancy-induced hypertension, nulliparity, multi-fetal pregnancy, FGR, and the male fetus. But there is no ethnic and the geographical distribution of the disease. Pathogenesis lies in the defect in the mitochondrial beta oxidation pathway, particularly in the long chain 3 hydroxyacyl CoA dehydrogenase, that is called LCHAD. This LCHAD is one of the four enzymes which is responsible for the long chain fatty acid oxidation in the liver. Defect in the LCHAD lead to accumulation of the long chain fatty acid metabolites produced by the fetus to the placenta. These metabolites are hepatotoxic and lead to the liver disease in form of the AFLP and also HELP syndrome. Clinical presentation is range from the asymptomatic elevation in the aminotransferases to fulminant hepatic failure. 1 to 2 weeks of the non-specific symptoms, which are anorexia, nausea, vomiting, headache, and the right upper quadrant pain. Later, it may develop progressive jaundice. Development of the complication can also be seen like hypertension, edema, ascites, polyuria, polydipsia caused by the transient diabetes insipidus, oliguric renal failure, GI or the intra-abdominal bleeding, hepatic encephalopathy. We categorize these patients. The diagnosis of the AFLP is made by the Swansea diagnostic criteria. 6 or more of the following features in the absence of the other explanation gives the diagnosis of the AFLP. These are the vomiting, abdominal pain, polydipsia, polyuria, encephalopathy, high bilirubin level more than 14, hypoglycemia less than 4, high uric acid more than 340, leukocytosis, ascites of the bright liver, right high AST/ALT level more than 42, high ammonia levels, renal impairments, coagulopathy, and the microvascular steatosis on liver biopsy. Investigations we do mainly the bilirubin. Usually it is less than 5. Aminotransferase level is can be near or up to 1000. Normostic normochromic anemia, leukocytosis, normal to low platelet counts. So thrombocytopenia in the third trimester should prompt the diagnosis. Coagulopathy with or without DIC, metabolic acidosis, renal dysfunction, hyperuricemia, hypoglycemia, and high ammonia levels. Biopsy is rarely done uh, when the diagnosis will change the outcome, but on the histology, it is the microvascular fatty infiltration in the zone 3 with the showing a cytoplasmic appearance, and there is lobular disarray with mild inflammation in the cholestasis. Differential diagnosis done with the acute viral hepatitis, especially hepatitis E, herpes simplex viral disease, drug-induced hepatitis, HELP syndrome, and the biliary tract disorders. Management is this condition is an obstetrical emergency. It does not resolve prior to delivery. So hemorrhage and the intrauterine deaths may develop if the delivery is delayed. So choice of the route of delivery is completely with the obstetrician opinion. If a C-section is done, then correct the coagulation disorder, especially thrombocytopenia. No specific treatment as etiology is unknown. Rarely liver transplantation may be required. Prognosis is the patient generally improve clinically and the biochemically shortly after the delivery. Chance of the recurrence in the subsequent pregnancy is there. Next symptom is the preeclampsia. Preeclampsia is a triad of the hypertension, edema, and the proteinuria. Incidence lies in the third trimester. It is 5 to 7% of the pregnancies. Liver involvement is not common in the preeclampsia. The mechanism of the injury involves the vasospasm and the precipitation of the fibrin in the liver. Histology, there is a periportal hemorrhage, ischemic lesions, and microvascular fat deposition. Clinical presentation is the nausea, vomiting, in the right upper quadrant pain. Liver enzymes are elevated, maybe 10 to 20 fold. This elevation reflects the development of the HELP syndrome. In most severe cases, progress to subcapsule hemorrhage or the hepatic rupture. Prompt delivery is indicated to avoid the progression to the eclampsia and the hepatic complication. Now the HELP syndrome. The true HELP syndrome is the triad of the microangiopathic hemolytic anemia. This term itself says the hemolytic anemia is there, elevated liver enzymes, and the low platelet counts. It is a true health syndrome. When it is a partial health syndrome, there can be, when there is hemolysis is absent, can be only the elevated enzymes. When the in which severe preeclampsia can be present, and it can be when there is HEL in which platelet counts are normal. So it can be a partial health syndrome also. This true health syndrome complicates 2 to 12% of the cases with the severe preeclampsia and about 0.2% of 0.2 to 0.6% of the all pregnancies. Occasional patients without hypertension and the proteinuria, but with defining criteria of the health syndrome can also be seen. Time of presentation is mostly antepartum, usually in the third trimester, mostly in the 28 to 36 weeks of gestation, but up to 30% patient in the postpartum period from the 48 hours after delivery to as long as 7 days after childbirth also seen. Pathophysiology is the disease of the abdominal endothelial reaction and the disruption. So there is abdominal trophoblastic implantation resulting in reduced tissue perfusion and the endothelial dysfunction. These platelet activation and the aggregation cause activation of the complement and the coagulation cascade, increase vascular tone and alteration of the thromboxane to prostacyclin ratio. So thus this endothelial injury result in the microangiopathic hemolytic anemia with schistiocyst seen on the peripheral smear. The liver enzymes are elevated because of the periportal hepatic necrosis. Symptoms are right upper quadrant abdominal pain and the tenderness. It is only symptoms in 50% of the patients. There can be nausea, vomiting, malaise, headache, edema in the weight gain. 85% patients have hypertension in the proteinuria. Jaundice is seen in the 5% of patients, more common in the older white multiparous women. Investigations are anemia with the schistiocyst on the peripheral smear. LDH is more than 600. Platelet count usually less than 10,000. Platelet less than 1 lakh. The transaminase levels are elevated. CT or the MRI scans show subcapsular hematomas, intraparenchymal hemorrhage, or the infarction of the hepatic rupture. Liver biopsy rarely necessary. Whenever done, it shows the periportal hemorrhage with the fibrin deposit. Differential diagnosis made with the liver involvement. First is whenever there is liver involvement, it is the differential diagnosis done with the AFLP. Whenever there is low platelets, we have to exclude gestational thrombocytopenia, immune thrombocytopenia, TTP, and the HUS. These conditions do not have elevated liver enzymes. And the HELP syndrome lacks the neurological and the renal manifestations found in the patient with the TTP and the HUS. Management is the antepartum stabilization. Temporizing methods are magnesium sulfate or for the seizure prophylaxis and the vasodilators in form of the Labetal or hydrocele nifedipine. In severe cases, sodium nitroprusside. Delivery is the definitive treatment for these patients. If no obstetrical complication or the DIC in the pregnancy near term allow normal delivery, most require cesarean section. So it is how the patient is managed after identification, monitoring, and the stabilization. Done the when the blood pressure is more than 140/90, the labetalol, nifedipine, and methyl dopa is given. If the blood pressure is more than 160/1110, it is hospitalization, antihypertensive therapy with magnesium sulfate. If the gestational age is less than 34 weeks, consider corticosteroids. Less than 32 weeks, consider magnesium sulfate. So, in patient more than 34 weeks, prompt delivery once the metal coagulopathy and the severe hypertension have been corrected. If the gestation is less than 34 weeks, expedite the delivery with optimizing maternal and the pregnancy outcome. Prognosis usually resolution of the HELP syndrome after delivery. Platelet levels normalizes in 5 days. Some may develop persistent thrombocytopenia or the hemolysis or complications of the HELP syndrome. They require antithrombotic agents, steroids, plasma exchange with the fresh frozen plasma and the dialysis. Neonatal prognosis, high perinatal mortality in these patients seen in form of prematurity, dismaturity due to placental insufficiency, consequences of the severe maternal complications. Recurrence occur in the 2 to 6% of the patient. Subsequent pregnancies carries a high risk of complications. There is no long-term effect. So the conclusion are these diseases, uh, they are exclusively in the pregnancy seat. So if we start with the workup, the proteinuria, platelet count, LDH, and the clotting abnormality, uric acid elevation, the creatinine elevation, they are seen mostly in the PET, HELP syndrome, and the AFLP. Hemolysis is a feature of the this eclampsia and the HELP syndrome. While in this patient, the AFLP, there is in the liver ultrasound, there is characteristic microvesicular steatosis noted. So, liver disease in the pregnancy can be difficult to manage due to the various presentation that range from subtle liver biochemical change to hepatic failure. Early detection, adequate monitoring, and the involvement of the experienced physicians within the multidisciplinary team can help improve outcome for these women and their babies. Thank you.